It's wonderful to be here, and I want to thank Jeff and Rod very much for allowing me to talk to you today. There is a but, and the but is that no hotel I ever stay in again will live up to this, so that's a pity. Great choice, thank you. The other thing is to squeeze me in between Sarah Hallberg, David Ludwig, Nina Teichholz, and the unwin pair is, I feel a little bit like if you've watched the Soccer World Cup and you have like the Brazilian team running out onto the field and there's this little kid carrying the ball. I feel like the little kid. So, David even told me last night he had time with the Minister of Health in the UK, 45 minutes. So these are very influential people, and it's wonderful to be here with them. Right, disclosures. So I'm going to talk about my disclosures, which are quite simple. I'm an employee for Swiss Re, and I'm a board member of Nina's Nutrition Coalition, for which I'm not reimbursed financially. So Swiss Re, different people pronounce the R-E differently. Some pronounce it Swiss Re. It's really Re, quite simply, and that is because it stands for reinsurer, right? So what is a reinsurer? Our clients are the insurance companies. So if you have life cover with somebody, Prudential, MetLife, a portion of that risk is actually reinsured with us. And if something happens to somebody and there's a payout, we make that portion of the payout. So the question is, why do we exist? Why do you need a reinsurer? And really for two reasons, a bit technical. The first is capital. So there are very strict guidelines as to if you have a portfolio of people that you are protecting their lives and you will pay out if they die, you've got to hold capital for that. And there are very strict rules around that. And these are called solvency rules, and one of the things that they look at when they look at solvency rules is how diversified you are. The more diversified you are, the less capital you need to have, because if you're geographically diversified, a pandemic in one area is not necessarily going to affect you as badly as if that was your only area where you were offering cover. And the other thing, of course, is volatility. So if you have a whole lot of people all taking out $1 million of life cover, and you've got the capital for that, that's fine. What happens when you have a footballer that comes along and wants $100 million, right? If that one person dies, it really skews things for you, and it throws you out. So we cover the volatility for the life companies. Another disclosure that I didn't put up here, but the people this morning did, is that I've had the conversion experience. Yay. But, there is a but. And the but is that I'm a little bit of a food addict, and so I know David's going to cover that a little bit. And so I struggle, like maybe some of you do too. But certainly, I very much believe in reducing your insulin load. Right. I wanted to just quickly talk about this. So yesterday, it was mentioned that we excluded certain groups. So we had this fantastic forum in Zurich in June last year. We co-hosted with the British Medical Journal. We had over 200 of the world's top scientists, researchers in nutrition. The BMJ and Swiss Re each were allowed basically 100 invites. We sent out thousands, as did the BMJ. We didn't exclude any groups. Really important that that is known. We wanted diversity of thought and diversity of mind. And yesterday, I really did feel that we had achieved quite a bit of success with Daresh Matsafarian being here and us listening to him, and I think a lot of people at that event listening to the other side. So very much what we wanted was different views. Okay, let's get to business. So I'm going to really focus on life insurance rather than medical insurance or reimbursement. So life insurance is really simple, right? For a really low sum of money, usually a monthly premium, you get protected so that if something happened to you and you died, a big sum gets paid out, right? So you can see there the little red dots, the little red lines would basically be many people paying small amounts. If one of them died, you have this huge payout. Now, that would be really easy, and in some countries, what happens is you have a group of people, a community, that put money aside, and if something happens, then that kind of lump sum gets paid out. Insurance has to reverse it. They have to go, that blue line is fixed. If you take out $1 million or $10 million, that's what we have to pay you, right? We can't go, well, we've only collected $9.5 million. So we have to pay you that. So we have to reverse that process and work out how big should those little red lines be for the monthly premiums that these people are going to pay. And that's quite complex. So how does nutrition fit into all of this? Really simply, if people are dying more frequently than we expect, we pay out more. If people are dying less frequently, we pay out less. Are we an altruistic, wonderful entity? No, we want to make money. We're a for-profit organization. But what's great is that our alignment is people living longer. And there's no vested interest other than that, right? We don't sell anything other than protection cover. So how do we price life insurance? I think this is really important for people to understand and maybe to see where we come from when I will talk a little bit later about the things that concern us. So for the wannabe actuaries in the room, that's a mortality table. And really what you see there, in the first column you've got age, in the next column you've got males and females, then you've got something called QX, which is really the mortality rate for that age, right? And then I've blown up for a 32-year-old male, you can see that the QX or mortality rate is 0.000997, which is 1 in 1,000, effectively, right? So 32-year-old males, based on this table in the UK, have got a 1 in 1,000 chance of dying in a year, in that year that they're 32, right? So our actuaries use this. However, what we do if you've taken out life cover is we underwrite people. And that's a process of doing risk selection. So somebody applies for insurance, and we do blood tests, we ask them a bunch of questions, we weigh them, and we decide how healthy they are, right? Now, clearly, we can't only offer the 12% cover that Sarah was talking about today. So we offer usually about 80% of people something which we call standard rates. And what you'll see there in the graph is that's really a proportion of people that are in different risk pools, and you'll see all the little kind of purple bars on the left side of the blue line where it says standard. Those are people with different risks, but we put them all together, because that's the process of insurance, right? It's big numbers and lumping people together. However, you can see with that arrow at the bottom, there's cross-subsidy. So you have these people on the far left-hand side that have a far lower risk than the people on the right-hand side. They all pay the same premium, right? But there's cross-subsidy. If we feel somebody's too unhealthy, we will expect them to pay a higher premium. So that'll be the substandard group. And then people that we feel are uninsurable because the risk of dying is too high would be declined. And the actuaries really look at the standard pool and decide how to price it. What underwriters do is they look at the substandard pool and decide how much to load that. So this is a little more complex than the table I showed you. This is a US table looking at male non-smokers from the Society of Actuaries. And that big red bar over there, if you look at a 52-year-old male, you can see that in the first year they've got a kind of a 1.3, on average 1.4 per 1,000 risk of dying in a year. Then if you move to column where it says 2 and it goes 0.00191, that's the next year. That's when that 52-year-old is in the second year of their policy. And so it goes along. If you look at column where it's the 9, the blue block, you'll see that their risk of dying is about 7 per 1,000, right? So now they're essentially 60 years old. And their risk of dying is 7 per 1,000. What's interesting, though, if you go and look at that purple block, if a 60-year-old applies for insurance, we expect their risk of dying to be about 2.3 per 1,000. So why does the new 60-year-old have a 2.3 per 1,000, whereas the 52-year-old, when they're 60 years old, they're sitting at 7 per 1,000? Do you all get that? Yeah. And really, it's because what underwriting does. It's called protective value, and we have what's called a select period, whereby we believe that the mortality is better because of our underwriting. And it's akin really to buying a used car, right? If you buy a used car and you have it fully checked out, it's going to do a lot better than a random car, right, that you just go and buy. So underwriting is very useful for that. But as time goes by, after you've bought that car, things are going to start breaking. And after a certain amount of time, it may as well be a random car, right? So in the US, they've got a very, very long select period, over 20 years. In most other markets, it's 5 or 10 years. And what you'll see over there in the black block, and this is quite important, I think, is that if you look at a 48-year-old male, the chance of dying is less than 1 per 1,000, right? So it's 9.4 per 10,000 or 0.94 per 1,000 for a 48-year-old male. Yet, when we looked at this graph, we had a 32-year-old with a 1 per 1,000 chance of dying. How can a 32-year-old have the same risk as a 48-year-old? And that is because this is general population, and that's something that is very important to us. We don't insure the general population. The general population includes people who don't have jobs, who can't afford insurance, who maybe don't have the education or the access to healthcare that the insured population has. So when you look at the insured population, it has a far lower mortality per annum than the general population. And in fact, this graph, this is looking at Minnesota data. 100% would be what the general population mortality is, and you can see there that for males in the orange line or females in the gray line, the percentage of mortality based on the underwriting year compared to the general population. And you can see in the first 2 or 3 years, it's less than half, right? Part of that's underwriting, but part of that is also the fact that these are people that have jobs, can afford insurance. So the insured population is something you'll hear about a lot. So that's mortality. How likely is it somebody's going to die? And you kind of think, okay, well, we have these tables, and then you work it out, and that's fine. But interest rates. So this money that you have to keep, the capital, right, that you have to keep to pay stuff out, you invest. And as that grows, that's great, and it means you can ask people to pay less premiums because you're going to make more money from your capital that's growing. That capital has to be very conservatively invested. You can't go and invest it in Apple and Tesla stocks, right? We're talking government bonds, really, really safe stuff, hopefully. Sorry. The other thing is lapse rates, right? So what happens is people's lives change, they lose their jobs, they change their jobs, maybe the kids grow up and they don't need, you don't need to financially support them anymore, and people lapse their policies, which means they stop paying the premiums and the policy ends, right? Now the question is, who is most likely to lapse the policy? More healthy people than unhealthy people. Someone's really unhealthy, and they think, oh, I could get a heart attack, I could die. They're probably not going to want to lapse their policy. So lapse is a real big problem for us, and it's a behavioral thing, and it's based also on the economy, and it's an assumption we make that is very, very hard to get absolutely right. So lapse rates are a big deal for us. The other thing related to this presentation is mortality improvement. So how old, we saw yesterday the blue zones that Gary's spoken about, right? We would love to just insure or reinsure the blue zones because people live for a very long time. But what happens, of course, over time, and we saw that yesterday as well, is cardiovascular diseases or death from cardiovascular disease has reduced. Death from cancer has reduced, right? So we know that people are living longer. I'm going to go more into mortality improvements. And then the other thing is intense competition. So we can't kind of go, yeah, we think people, a 40-year-old male wanting $1 million should pay, I don't know, pick up a number, $200 a month. So yeah, just to be safe, we'll charge them $220. We can't do that. There's intense competition, and we are pushed down to the very lowest possible premium, right, by our competitors. And it's good for the market, it's good for the consumers, but it does mean that we're very, very close to where it becomes not profitable. I want to show you this. Longevity is a big deal for insurers and life insurers. We're a composite, so we do life and non-life. But this is looking at females age 65 in the US and how many more years of life they have left. And what you can see, and this is 1900 to around about 1980, is you can see that the years expected to live on past age 65 has increased steadily. And we know why that is, right? Then what you'll see is those straight lines are all projections that were made at that time. So 1952 projection was made, 66, 74, and the projection was made, where do we think this improvement's going to go? And what you see is that the observed, the black line, has always outstripped the projections. So we thought in 1952, right, by 1990 maybe they'll live to 16, but what happened is they went up to 19 years of life beyond age 65. So we've always underestimated the improvements in mortality until. So what you can see, the black line down there is observed 1980 to 2000, and then you can see some projections made in 1981, 1984, and you can see that the projections are higher than what we observed. So things are beginning to turn around and reverse themselves. And if you look at kind of a linear extrapolation, that red line, you can see that the projections are now going below that linear extrapolation of where we are, or rather where we were with time before 1980. So the big question for us as life insurance and reinsurance companies is, what does the future hold? Huge deal for us. Doesn't look that great at the moment. Important, this is general population data. And again, what we see in the general population is not what we see in the insured population. It's different, right? It's a bit what Gary was talking about in a way on the stage yesterday, saying, you know, this group, it's kind of rarefied understanding of nutrition and everything else. In another way, in insured population compared to general population, people are just more educated. They are more likely to be low carb or keto. They're more likely to be looking after themselves. So this is not saying this is insured population, right? This is general population. But you can see in the UK, this is mortality improvement. What's important, this is 5-year average. So when you look at 2016 and you see it's below 0.5%, that's the 5-year average that's going to below 0.5%. So what you're seeing in 2016 is below zero, right? Mortality improvement is essentially reversing. And then you can see life expectancy, and there's life expectancy always from birth, and then from age 65, you can see the steepness of the curve is certainly slowing down. US and Canada, same thing. And there have been big headlines because 2015, 2016, 2017, 3 consecutive years of life expectancy dropping for the US general population, right? Really big deal for us, something we're very worried about. The headlines almost always focus on non-natural deaths, so things like suicides, overdose, the opioid epidemic's a big worry for us because it really does seem to affect everybody. So this doesn't look good. Interestingly, this one from the New York Times, no, not the New York Times, from Time magazine, mentioned diabetes, right, as one of the things that have increased. And if you look at the table on the right, from 2016 to 2017, deaths per 100,000, you can see that diabetes went from 21 to 21.5. So it increased, but then you look at heart disease and cancer, they've decreased. I'm going to come back to cause of death, because I think they are very misclassified. So why should nutrition matter to us? You can see cause of death in different regions around the world. Europe at the bottom. The Americas are the second group over there. And then you can see these pie charts. And when you look at the pie charts, When I saw this for the first time, it worried me because you see diabetes for females 2.7% and for males 3.1%. So there's about 3% of deaths caused by diabetes. 6 of the top 7 causes are non-communicable diseases globally. Diabetes is ranked 5th, 7th, and 8th in these different regions of the world. But we know diabetes is very strongly associated with all those diseases. And if you look down there in Europe, you can see that kind of 6 of those are all around this metabolic syndrome derangement. And so maybe this 3% is a little bit of an underestimation. So this was a study done in 2017 by Andrew Stokes, and he looked at 2 surveys, NHIS and NHANES, and he actually went into the data, and they asked people self-reporting, and they also looked at A1C, and they looked at something called population attributable fraction, and they had a look to see what is the likelihood of diabetes leading to the death of those people, and they had far higher numbers. They were sitting at 11, 12%, right? In obese people, it was almost 20%. That's a far cry from the 3% we saw in the previous chart. And of course, the younger the people are, you can see that almost a third of deaths occurring in adults under age 60 attributable to diabetes. That's from the IDF. So clearly, it's a big concern. We worry more about death than about live patients that you people do and looking after them. So this is a study from Sweden. They looked at the Swedish diabetes register, and they compared a whole bunch of patients, diabetic patients, hundreds of thousands, compared to controls, and then they looked at cause of death. And what you can see, if you look at those top 2 red blocks, if you look at kind of all-cause mortality, it's double, right? Diabetes patients compared to controls. Of course, this is old data, because with Andreas and his success, there are probably no diabetics left in Sweden. But it does highlight the fact that diabetes is a far bigger indicator of mortality than, and cause than we're currently seeing. And this was one of the conclusions from the Stokes article. Proportion of deaths in which diabetes was assigned as the underlying cause of death severely understated the contribution. Right. So diabetes is a big problem. And then, of course, we have obesity. It's not even listed as a cause of death, right? Yet we know it's strongly associated with a whole bunch of things. And we know that these people get heart disease more frequently, they get strokes, and there's an increased risk of cancer. And we know that the trends of obesity and diabetes, so those are different regions in the world, those are different age groups in the US on the left-hand side, it's increasing, right? Obesity is increasing, diabetes is increasing. We've seen lots of information on that in the last day and a half. And we know they're effective strategies. These are just you've got the direct trial, we've got low carb, we've got ketogenic, essentially, David Unwin's work from the UK. And then, of course, we know that surgery can help as well. So we know they're effective nutritional strategies and other strategies, yet we have this continual explosion, right? So for life insurers, it's all-cause mortality. So often we see studies and it's cardiovascular deaths or deaths due to stroke. From a corporate point of view, we don't really care. If somebody dies, we pay them, right? So it's always all-cause mortality that we focus on. And as much as, okay, so we don't have long-term data, right? We're going to soon have 3.5-year data. That's fantastic. But that's not long-term data in our world. In our world, we're talking 30, 40 years, right? That's what we want to see. However, we know that when we reverse diabetes and people go low carb, we get massive improvements in risk factors that we use to rate people. So we rate people based on BMI and lipids and fatty liver and all these other things, right? We know that increases your risk. We know inflammatory markers go down. And I'm sure I just quickly threw these out yesterday, but we know these improve. And the assumption, therefore, is we're going to have lower deaths, right? It's like obvious. Can we bet that obvious? Right? Can we make a bet on that? And that's very, very hard for us to do because we don't have long-term data. Gary Tarp sat here yesterday and said, I hope I don't die prematurely, right? He doesn't expect to, and I'm sure most of you don't expect to, but we don't have long-term data. And that is an issue for us. And then, of course, you get things like this. Again, this was spoken about yesterday. This is the age for that looks a lot like dinner last night, for those of you at the speaker's dinner. So, this is low carb, was supposedly less than 45, it's association. Do we ignore it? As an organization that puts a lot of money behind looking at nutrition and nutritional strategies and what could make people healthier, we're working a lot, in a slide or two I'll show you, with many partners around the world. We want to try and get people on the right nutritional track. We want to try and get them on the U-turn that Sarah spoke about to reverse diabetes and put it in remission, right? But we have to constantly keep an eye out for things like this, and we have to look at them, right? The other thing, I said we are a composite reinsurer, so we do people and we do things, right? So we reinsure people, lives, disability, etc., but we also insure property and casualty. So property, cars, buildings, bridges, jets, tunnels, etc., but then we also reinsure liability, right? And as a company with billions of dollars in capital, if we tell people to do something and they die, no causal link, but someone says, whoa, that's a big target over there. They've got a lot of money, right? And that's what we have to be careful of. And that is why in the last two and a half years, while I've been looking at this and really trying to get my organization behind it, we've had to kind of follow the standard of best care, right? And where we're at now, what the guidelines are saying now, it's safe. A year ago, maybe less so. So we've really had to be careful around this. We've done a life insurance impact model, and again, what's interesting is you look at this, only 5% of a kind of portfolio is diabetic, which again, and 18% pre-diabetic, which is a lot less than you'd get in the general population, right? So we looked at this and we said, you know what, if we could get these people on the right track nutritionally, how could we reduce our claims? And you can see almost a quarter fewer claims in diabetics, and then as you go up, and these are really, we don't have long-term data, right? So it's a real thumbsuck in terms of how significant the claims reduction will be. This was very conservative. I had to really fight, but I was kind of pushed back because I think the claims reductions will be a lot higher. But again, that's just an assumption because we don't really know. So according to the whole portfolio, our actuaries worked out this would be a 13% overall reduction if we got these people on a nutritionally good wicket. Health expenditure, I'm not talking about too much. We've had lots of discussions yesterday about how much this is costing everybody. You've got data from the UK. It's crushing the NHS. You've got data from the US. It's absolutely huge. What's really important is the difference between private and public healthcare. Where there's a public system and the government is paying for it, I think it's far easier and it's going to be far quicker to get this strategy on track in a national way. Whereas where you have private funders, all they do is increase premiums, right? It's a lot harder to twist their arm. Yes, they can reduce premiums if they can get this right, but I think the incentive for public health care is far greater. So our vision as a corporate is that we make the world more resilient. And that's whether we replace somebody's house, or we help a family when somebody dies, or we help an individual when they cannot work, is that we make the world more resilient, right? And it's a great vision that our company has. We're involved in terms of this nutritional side of things. We're involved in research. So we've had the BMJ event food for thought. We're in discussions with them. Maybe we'll have a second one next year. The fact that I'm on the Nutrition Coalition, as somebody who works in a big corporate that's very concerned about reputation, I had to get lots of permission to get onto the board of the Nutrition Coalition. But the fact that they allowed me to, I think we realize what the impact is here. And then we're involved in lots of other initiatives, some of which I cannot share, but all around this nutritional strategy. In terms of wellness, so many companies have wellness programs, and generally it's, do exercise, sleep properly, wear a Fitbit, and eat healthy food, right? And that doesn't seem very effective. So in terms of wellness, what we have been looking at, and I've been really integral in this strategy, is looking for partnerships around the world where people are doing what generally this group would suggest for metabolically unhealthy people, right? And those are the partnerships we have, and those are the partnerships that we are trying to use with our direct clients to get them to either in their in-force, so people who already have insurance, to try and get those people, right, to be aware of what their nutritional strategy should be, and then also people who buy insurance now, new business, right? So people buy insurance, they're diabetic, we could really help them if we get them on the right track. So we are really trying to shift the needle, we're really trying to move things. I've got 3 minutes, that's fine, because I'm done. So thank you very, very much.